11, and 12. Well done, well done. Straighten legs. Before we go to our rest, we're going to do jumping jacks. 12 of the same. 1, 2, 3, and move. 4, 5, 6, 7, 8, 9, 10, 11, 12. There we go. Our rest time starts now. Our rest time starts now. Make sure you stretch as you go along. You could as well stretch on your rest time. Get this joint moving. 5 more seconds to go. 5 more seconds to go. Our time's up. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, keep going, 12. Well done. Now we're going to do jumping jacks. Are you ready? 1, 2, 3, and go. 1, 2, 3, 4, 5, 6, 8, 9, 10, 11, 12. Our rest time starts now. Our rest time starts now. Breathe in and out. In and out. Three more seconds to go. There we go for the last set. Are you ready? Last set. Last set. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Then we do the jumping jacks. Are you ready? 1, 2, 3, and go. 1, 2, 3, 4, 5, 6, 8, 9, 10, 11, 12. Well done. The rest time starts now. Breathe in, walk around. In. Alright, so we're going to do our next workout, which is basically step up on this beautiful stool. So if you're using just a normal stair, if that is high enough for you, you need some height that is a little bit challenging, but within your limits. I don't want anyone to fall, you know. Yes, so Get something within your limit. So what we're going to do, let me move the water bottles here and demonstrate first without the water bottles. You're going to step up, all the way up. The leg that goes up first is what goes down first. The leg that goes up first is what goes up first. I love this workout because it helps you engage the back side of your leg, which is basically the hamstring and the glutes during, when you're pivoting up, so that you're able to have strong legs right from behind all the way to the front. So we're going to do 12 on each leg. That's one set. 12 on each leg. Non-stop. 1, 2, 3, and move. 1, 2, and don't hold your knee to pivot up. Try not to. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now we start with the other leg. Remember, the leg that goes up first is the leg that comes down first. 1, 2, 3. Control your movement back. 4, 5, 6. Keep going. 7, 8, 9, 10, 11, and one more. 12. Now put that aside and we do one more workout before we go to our rest. So while you're here in a squat position, you go there. 1. Yes, let's go. 2. You're doing 12. 3. Make sure you're feeling the pull here. 4. Sit on your bum. 5. This leg completely straight. Alright. 7. Keep going. 8. We work out the inner thigh. 9. 10. Keep going. 11. And of course, 12. Well done. Your rest time starts now. The rest time starts now. Walk around. Our time's up. Our time's up. All right. We'll start from the top again. We'll start from this. And then we go to the other sliding one. By the way, the sliding one felt so good. Yeah. 1, 2, 3, and move. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, course, 12. Other side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, keep going, don't stop, 12, perfect, put it aside, there we go, hold it up, 1, 2, 3, and go, 1, sit on that leg, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and of course 12. Perfect. Your rest time starts now. Your rest time starts now. Walk around. Walk around, walk around. Take some water, hydrate. As we prepare the setup for the last set of that workout, right? And our time's up. Our time's up. Our time's up. 1, 2, 3, and move. 1, 2, 3, 4, 5, keep going, 6, all the way up, 7, 8, 9, 10, 11, and of course 12. The other leg. Let's go, let's go, let's go, let's go. 1, keep going, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, one more, 12. Well done. Move it to the side, move it to the side. Let's do the side. We're going to do the side lunges. 1, 2, 3, let's go. 1, 2, 3, 4, 5, 10, 11, 12. Well done for completing that set of workout. Our rest time starts now. Thank you for doing that workout, executing it well, sitting on that bum, making sure we work this and this. Okay, alright, and the inner part of the thigh. Just walk around, walk around, walk around. Right. Let's see how many seconds left. 5 more seconds of rest. 2 more seconds. And our time's up. Our time's up. So for our next workout, let me put this stool aside. Let me put this stool aside. Right? Then we go for our next workout, which we are going to do pulsating squats. We're going to do pulsating squat and wall sit. So basically what I mean is this. My goodness. Let me try and secure my water bottle. Let me see. Oh, this is gonna drip. Let's get another one. Let's get another one. Perfect. Now, we're going to be here. 1, 2. We're going to do 20 of those, and then we go to the wall and just here, sit there, and touch like that. Alright, for 30 seconds. So we're going to do 30 seconds, 30 seconds, 30 seconds, 30 seconds. Sorry, 20 reps, 30 seconds on the wall. Alright? So let's go. 1, 2, 3, and move. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Perfect. Let's go to the wall. Wall sit. 30 seconds. 90 degrees. Arms up. We have 10 more seconds to go. 10 more seconds. Keeping it up tight. Stick to the wall until we hear the timer. 3 more seconds. There we go. Our time's up. Our time's up. Alright. Oh my goodness, that wall sit burns. Our rest time starts now. Our rest time starts now. Our rest time starts now. Walk around, stretch those legs. That wall sit burns on the legs, burns on the shoulders. Yeah, yeah. So we have 2 more sets of that. 2 more sets of that, and my dress is now wet. All right. We're gonna go again. Then put this here. 1, 2, 3, and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and of course 20. Let's go to the wall, to the wall, to the wall. Our wall sit starts now. Arms up. Don't drop, hold it, hold it. Hold it, hold it. We have 15 more seconds, hold it. I know you're feeling the burn, but hold it. 5 more seconds. And our time's up. Our time's up. Our time's up. Our rest time starts now. Our rest time starts now. Our rest time starts now. Walk around, walk around. Walk around. Walk around, walk around. All right. All right, all right. Okay. Last set of our workout. Last set. Let's go. 1, 2, 3, and move. 1, 2, 3. Nice and slow. 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. To the wall, to the wall, the wall for wall sit. 30 seconds wall sit. Starting now. With your arms up. Don't go down, don't go down. Hold it at 90 degrees, hold it. All right, 5 more seconds. We're almost there. And our time's up. Our time's up. Well done. Well done for completing that workout. Our rest time starts now. Our rest time starts now. Walk around. So just as our finisher, we're going to do jump squats, right? The jump squats, tapping each ankle, counting as 1. We're going to jump, tap this ankle, that's 1, right? So legs together, that. We normally do it for our warm-up, but today is gonna be our finisher. So we're going to do 15 times 3 as our finisher for the day. Your host has been Evelyn Owala of Eval Health and Fitness. You can follow us on Instagram, Facebook, or on Twitter. EVEAL on Instagram, Facebook, or Twitter. 1, 2, 3, move. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, go down, 12, don't bend, squat, 13, 14, 15, well done, your rest time starts now, your rest time starts now, your rest time starts now, walk around, walk around. This session has been amazing. I'm feeling all ready to conquer this day. Thanks to Tizi Nyumbani, because I do this at the comfort of my home. I sweat it out, kill it, and let everything start with good energy every single day. Our rest time's up. 1, 2, 3, and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, and 15. Well done, well done. You made it to the last part of this workout. Thank you for joining us here at Tizi Nyumbani. It is amazing having you. Now go out there and conquer the world. Have a lovely day and look out for Peter in our next episode. Bye-bye.
Jack Tulliver is no ordinary thief.
Captain Jack Tulliver, disgraced Delta Force Commando.
Very good.
He's got one last score.
I sure hope you have big pockets.
To leave the game for good.
We're about to be $20 million richer.
He's assembled the perfect team.
This place is smoking up, baby.
For the ultimate heist. Nothing could possibly go wrong.
Let's go.
But in 7 seconds,
We'll be hit.
everything did. 7 seconds.
Greener vegetable oil stays liquid to the last drop, so it's smooth cooking from start to finish. Now with an easy-to-pour cap, mapishi poa, madishi poa.
Let's go, Kenya.
I'm Jambo of Kenya. This is Najib Balala, Cabinet Secretary for Tourism and Wildlife, Kenya. Join me in watching the London Marathon live on NTV on Sunday, 4th October 2020. Hashtag Let's Go Kenya. Hashtag Magical Kenya.
This is NTV.
Good morning, East Africa. Thank you for joining us on your world. Hoping September is going well for you. Now, the fear and stigma surrounding COVID-19 now threatens to cripple the gains made in various core pillars of health, including reducing maternal and infant mortality in the country. Now, various stakeholders and the government have raised concern on the same. And this morning, we talked to some of them as we take stock of the state of maternal health in the face of the pandemic and beyond. My name is Gladys Gachanja, and this is what else you can expect on this broadcast. How much has maternal health been affected by the pandemic? What can be done to safeguard our mothers? Well, let's find out in a few. Mali junta has established an 18-month transition government as a plan to stabilize. Yemeni infants get treatment at the anti-malnutrition ward in Al Sabin Hospital in Sana'a as millions of children in the war-torn country are at the brink of starvation. Tourists flood Mexico as it reopens its most treasured attractions. Thank you for joining us on this broadcast. So our question of the day to you this wonderful Tuesday morning is, what is the biggest hurdle in accessing maternal healthcare services during the COVID-19 pandemic where you are? What are the challenges of accessing maternal healthcare services where you are? Talk to us. That hashtag is the new normal on our social media platforms. And you can call us or text us using that number at the bottom of your screen. Now, take a look at the effects of COVID-19 around the world in terms of numbers. Globally, that number stands at 29,442,360 people confirmed to have COVID-19, 21,276,665 people who have totally recovered from the same. And unfortunately, globally, we've lost 932,744 people to COVID-19. And now in the country, as per yesterday's briefing, 36,205 people have been confirmed to have COVID-19 so far. Out of those, 23,243 have totally recovered and 624 Kenyans have unfortunately succumbed to COVID-19. We keep you updated every morning of the numbers right here on Your World and of course in our subsequent bulletins in or on NTV. So stay with us. And speaking of which, let's take a look at the global scene in as far as what is topping the headlines. Mali's military junta at the weekend vowed to establish an 18-month transition government to return the country to civilian rule after last month's coup, but key figures protested the army's continued influence. A junta-appointed committee adopted a transition charter by acclamation at the close of talks on the handover of power, a move that paves the way for a placeholder government taking over before staging fresh elections. But one of the most contentious issues remains unclear: whether the transition government will be headed by a civilian or a soldier.
Tout le monde est installé.
About 50 people are feared dead after a gold mine collapsed in the Eastern Democratic Republic of Congo following torrential rain at the weekend. The accident in the makeshift mine occurred in the town of Kamituga in South Kivu province. The provincial governor says the accident claimed more than 50 people, most of them young, and a witness says water went into 3 tunnels. When people tried to get out, there was no way as the water was flowing strongly with high pressure. The mayor decreed a 2-day mourning period and called on local residents to help extract the bodies from the ground. Still in the continent, hundreds marched in Angola's capital, Luanda, on Saturday to protest against police brutality after a doctor caught breaching anti-coronavirus rules died in custody. Police claim Silvio Dalla, 35 years old, suffered a heart attack after he was arrested for driving without a mask on September 1st. But questions were raised after Dalla's body was sent to the morgue covered in blood with scarring to his head. The doctor is believed to be the latest victim of security forces violently enforcing lockdown rules in the impoverished southwestern African country. At least 7 young men were shot dead by police and army officers between May and July, according to Amnesty International. Elsewhere, Namibia officially reopens to foreign visitors in a bid to salvage the tourism industry hard hit by coronavirus restrictions. Hotels and restaurants in the country are eager to welcome tourists once more after a months-long and economically crippling lockdown.
It hit us so badly that we psychologically were considering to close the business completely. But then we thought it's not a good idea because then people were already rumoring that Josie's closed down. And we had about 10 takeaways, deliveries per night. That is nothing. I mean, we have 75 tables. We can seat 650 people on a busy night. So 10 deliveries per night. I mean, it's not even 2% of the whole thing.
Average number of visitors are between 2,000 and 4,000 per month. That's usually. We've maybe seen 150 per month. So that is the tragedy. You know, the craft center is over 20 years old. And the craft center support directly about 80 people, you know, in the center with direct employment. But indirectly it buys and supports crafters and traders of 5,000 to 6,000 people from all over the country. So when we don't sell, we don't buy. When we don't buy, the people suffer.
Taxi business around here is not making money because people are scared of each other. No one will want to go in the taxi where you can see there's someone else. He wants to go in that taxi because he's scared. Maybe that person who's inside of the taxi is having corona. So people, they are scared to be affected. They are very careful because they know that there's no vaccine for them.
The international tourism market, I think it's going to take more than a year to recover from that. And then for the locals, we've dropped our prices. And I must say we've had a very good response from our locals, especially the winter people, since we're still in a lockdown now. The Commerce region, they've supported us very, very well. And I'm very grateful for that. But yeah, it's sad that the internationals can't see our stunning country.
The government needs to limit verantwoording vat vir wat hulle doen. They're not doing their job.
The city of Cape Town says it has demolished over 50,000 illegal structures in just over a month as land invasions increased during the COVID-19 lockdown. Land invaders insist they have been forced to take the land as they have nowhere else to live and need the space for their safety and dignity.
Take our land. Now we want them to take it out. They must go out back where they come from.
Some of us, like me, I lost a job. Like after I lost a job, I never had a place to stay anymore. Now, like I'm renting, I went out to the rent, looking for a place to stay. I put my walkie there. The reason was to having my own place to stay where I'm not going to rent.
Even if they kill me, I still can get shot for no reason, for walking to the shop. So why can't they kill me if they want to shoot me for my own house? I'm not doing this for something small. I'm doing this to build a family so that each one of us have our own privacy. Where each one of us have our own dignity. Where I can say, that is mine. Nobody can remove me.
When people are weaponized, when people are armed and they want to coerce the government to give them special preference and special treatment above other people who are also vulnerable, also disabled, also women who have been promised a particular property. So we condemn that in as strong as possible.
Since the 11th of July, we have had to attend to 58,478 structures. So we're nearing the point where we will probably do in a month and a half or 2 months what we did in an entire year, the worst year to date. So I think it is undeniable that there is a self-evident link. What has clearly happened is that people have taken advantage of the initially well-intentioned provisions in the lockdown regulations that said you can't evict somebody. Now, many countries have used provisions like that.
Now back home and to a story that puts us in focus on our conversation of the day. The Ministry of Health is raising concern about the number of expectant or young mothers who are no longer seeking crucial antenatal and postnatal care in hospitals for fear of contracting the coronavirus. There are fears this could derail gains made in improving maternal health care. Eunice Omolo looks at how in the age of this deadly virus, new life hangs in the balance.
Mishi Kitsao from Kilifi cuddles one of her 4 bundles of joy. Her baby girls were delivered 4 days after Kenya announced the first coronavirus case. Her little bundles were underweight at birth and had to be admitted to the high dependency unit. And with every passing day, she and the doctors at the hospital feared for her children. Mishi is a statement to the disorienting changes that expectant women face in the age of the coronavirus. Expectant women around the country are having to confront an unexpected layer of stress due to the pandemic as healthcare workers rethink how best to offer prenatal care and keep the mothers and their children safe from the virus ravaging the country.
Usually as a country, we do have statisticians who work with us and are able to model for us the expected number of deliveries every day in this country annually. And so we do have projections of how many mothers we'd be expecting to see in our healthcare facilities. When we compare these numbers as at this quarter with how we were last quarter, we are seeing that there's a drop in health-seeking behavior.
Health administrators in Kilifi County are concerned that fewer expectant women are seeking prenatal care in hospitals and clinics, and even fewer infants are being brought in for essential vaccines and care.
Wakina mama wajawazito wanaokuja kliniki antenatal, wakina mama wanaojifungua hospitali, wakina mama wanaokuja baada ya kujifungua tunaita postnatal, wakina mama wa family planning, wote hao idadi yao imepungua chini. Zote katika public hospitals na private hospitals.
The county is now worried about a surge in birth-related complications as mothers shun hospital visits.
Piga simu mama, kama unaogopa kafyu huko nyumbani, piga simu. Kama ni hapa hospitali, ambulance ikuje hospitali, ikubebe, ikupeleke paka hospitali, uzae hospitali. Ni hatari kuzaa nyumbani kwa sababu una complications nyingi.
If a mother fails to take a child for vaccination, for example against polio, we are on track to be able to eradicate polio. So if 1 or 2 mothers fail to be able to take their kids for polio, then it means we cannot be able to reach our target. And that not only puts Kenya at a risk, but the entire African continent and the entire globe.
The fear of stigma surrounding COVID-19 now threatens to cripple the gains made in various core pillars of health, including reducing maternal and infant mortality in the country. Eunice Omolo, NTV.
And that is the basis of our conversation this morning as we take stock of our maternal health in the country in the face of a pandemic. To help us understand the same, in studio, Angela Ngoko, who is an executive director at the White Ribbon Alliance Kenya. We are also joined in studio by Dr. Stephen Kaliti, who is the head of reproductive and maternal health at the Ministry of Health. We're also joined virtually by George Owele, who is a community health strategy advisor at AMREF, and Nerima Were joining us virtually also, who is the program manager, sexual reproductive health rights at CareLane. Thank you all for joining us on this crucial conversation. And I think, Angela, the story we just watched kind of gives us a perception of what's going on. So the reduction in seeking prenatal services for fear of contracting COVID-19, how does that look like on the ground many months later?
The fear is still real. Women are still afraid of going to health facilities because of various reasons. Of course, the initial reasons were the myths and misconceptions that were initially felt across board when the disease was registered in Kenya. But more to that, and I'm speaking this from a survey that we did in 6 counties in the month of April and May. And we still continue having our listening exercises across the counties that we work in. There's the aspect of the misconceptions are still ripe. The health worker, the fact that some of the health workers were changed from, the focus was moved from the essential services like reproductive maternal health services to focus on COVID. So now, and what sank, and I think you all know that Kenya is a country where once a myth is spelled out, it will take forever for it to be changed. So there's the aspect of, if you go to a health facility, you will not be attended to, because everyone who goes there is one who is the only people who are being attended to are the COVID patients or COVID clients. More to that, the aspect of when you go to a health facility, you are going to be stigmatized. You're going to be, they will look at you like you have COVID. So they start fear and of course across board. I don't really blame the citizen. I don't blame those who are pushing around those fears. It's the aspect of health literacy, and that takes us back to where we are coming from. The response, as it was the first time when COVID was reported in Kenya, the response was so much of, let's act and curb this. Everything else stopped. And everything else was, it was not until much later that the RMSCH, or Reproductive, Maternal, Newborn and Child Health Services, were pushed back and guidelines given as essential services. I think it's in June when now the continuity of care of maternal and newborn and child health services was made as part of the essential package. So it's something that has been done much later. And I keep on saying that if at all we have done that even before. Someone can actually argue and say, Gladys, you know what? We're in a pandemic. It's an emergency. But had we done that before? Had health literacy be something that we've been doing over and over again? Had we involved people, citizens, or players on the front line to actually showcase or model how this should look like? I don't think we could be where we are today.
Yeah. Okay, now George Owele, you work with community health volunteers directly, and these are the people who know how the women on the ground in their homes are faring on. Reports have been said there's been an increase in delivery in the homes. Is this the case?
Thank you, Gladys. Good morning, all. True, yes, that is the situation as it is now. Many deliveries are at home and in the hands of unskilled personnel is experienced. This is because of the fear of going to the health facilities where they are not sure of the expectations. Most of them, when they go to the health facilities, they come back and report to the community health workers that the services are not accessible because the lower end facilities like the dispensaries and the health centers, the staff did not know what to do because they also feared the people coming from the community could bring infections in the facilities. And therefore, there was some go-slow in terms of availability of the services and access to the same. And therefore, it is true, we have experienced information or reports from the community health volunteers of increased home deliveries. And this really affects the quality of care, health care that the woman should expect during the ANC antenatal period and postnatal period in the country.
Okay, now Dr. Kaliti, the Ministry of Health is charged to ensure that these essential services are always there. They are consistent and catering for our mothers. What are the reports you are receiving? Are we doing better now than we did a few months back?
Thank you for that, and I recognize what my predecessors have just said about utilization of services. But what I've just heard is very true as it happened around March when we first had the first incidence of COVID-19 in the country, and the country was responding. Let me just say that, like any other health system, COVID-19 was a stranger to the health system. It came and caught the globe sort of flat-footed, not only Kenya, but across the world, and people are basically scrambling to respond. When you are faced with an existential threat or a threat to your existence, then the normal response, and the health system is not an exception, is that of fear, of flight and fight. So what we saw in the first month, especially March, between February, March and April, we saw a lot of fear that went across, and that's where the myths generated, and they ran around that I cannot go to a hospital because I'm going to contract COVID-19, the people are not skilled, we do not have ABCD. That permeated very quickly across the country, and we saw many mothers sort of shy away from utilizing healthcare services, and that's what just our top leadership has just said, that we saw a drop or sort of a dent within the utilization of healthcare services, especially reproductive maternal healthcare services. But given the role of the Ministry of Health in its central way of giving direction and policy to be able to make sure that each and every person is covered at any time and quick response in that matter, then the ministry set out very clear guidelines on how to revitalize and to be able to reactivate the essential services and especially reproductive maternal health care services within the time of COVID-19. And Kenya is a country of firsts, and I want to say very proudly that Kenya was one of the first countries across the globe, including leading the Western countries, in developing very specific guidelines, and I do have a copy here, that went across the entire country to make sure that these services are actually reactivated and they go, back as quickly as possible. And when that one came in, we went to each and every corner of this country. Of course, the public facilities that offer deliveries to the public, we have more than 6,000 facilities across the country. We reached each and every one of those facilities, and we set up the guidelines and the standards, and we put up the measures, basically reestablishing the systems in a very short time to be able to get mothers back to facilities. That said, there are a few challenges that came up, and we do appreciate the good work that our partners have done to be able to work together in terms of a collaboration, because our health is for, everybody has a role to play, right from the patient to the community, to the partners, to the government. It's just that as a government, we take the overall responsibility and the burden of making sure that each and every Kenyan is reached with the right quality of care. So during that time, we went flat out and basically set out a lot of guidelines and messages to get people back to utilize the healthcare services. And as a government also, we went flat out and made sure that the healthcare providers are prepared. It may not have been 100%, but definitely we moved the healthcare providers across the country from a 0% maybe to around 80% preparation to be able to handle that. And it also called for a lot of restructuring of the way the healthcare system has been, running in the country.
Okay.
Let me say this.
Dr. Kaliti, let me stop you at that point. We'll come back to, of course, the health infrastructure and boosting the same. Let me go to Nerima. There's a lot of there's communication that there was a problem in as far as how we communicated what COVID was, the impact of the same, and especially for the women and the mothers who were expectant and looking forward to the services in a hospital. Where are the gaps and what's the ideal situation?
Thank you for having me, Gladys, and thank you, colleagues, for your questions thus far. I hope you can hear me. So in terms of communication, I think the main gap has been, and this is what Dr. Kaliti has just said, there is a policy on reproductive maternal newborn health from the government of Kenya during COVID-19, which was provided as early as now. However, this was a national government policy that is not to be implemented by county government, because maternity care is a primary health care service. Therefore, we started to see problems whereby when we would see gaps in implementation in this policy and raise this to the national government, because questions were raised to Dr. Patrick Amoth, the response was, that is not our duty. And this has been the problem even since 2016, when the free maternity care package was suggested by the national government, whereby it was made by executive directive by President Uhuru, but to be implemented by counties without consultation. And this is a continuous problem with how the healthcare functions between the national and county government, though divided, are not being well implemented or coordinated in a good way. We see this in Homa Bay and in other counties, whereby women don't know where they can get services, how they can get services, particularly during emergency hours. However, when you seek answers as to how this can happen, you're directed to either the national government or the county government, when no one has any clear answers on what is supposed to happen during emergency hours. And the policy that was provided by the Ministry of Health in April doesn't clarify that. What happens in curfew hours when I can't actually leave my house without possibly being criminalized? This was raised also in an access to information petition by Kellen and other organizations to the Ministry of Health and other government arms, asking, Kenyans don't have accurate information to continue to both live their lives, prevent infection, and access services. It's a huge issue, particularly around maternal and newborn care. Vaccinations have gone down, women are giving birth at home, and this has been noted by Angela and by Chris. So when we ask the government, can you please respond to how you plan to proactively provide information to Kenyans? They haven't responded to the petition yet. So it's a continuous challenge in how the national and county governments interact in providing the health function. Decisions are taken at Afia House. However, the implementation is supposed to take place in counties, but there is no significant consultation between these two levels of government. And this is to the detriment of Kenyans.
Okay, Dr. Kaliti, let's come back to you. There seems to be a miscommunication between the two arms of government. How best can you work on ensuring that the information from the Ministry of Health trickles down to the county, which actually is supposed to devolve these services directly to the people?
Thank you for that. But let me say very categorically that it is not correct that there is a miscommunication. I wish you could see the kind of interaction that exists between the counties, top leadership through the Council of Governors and the counties, and our top leadership, whether it is at the level of our cabinet secretary, whether it is the level of our permanent secretary, principal secretary, whether it's the level of our directors. There is constant engagement and there is no time. Let me tell you, the first schedule of the Constitution of Kenya is quite clear on the mandates and the roles of each and of these arms of government. While formulating policy, it is supposed to be a consultative process that includes everybody, includes the players. It is the desire of the ministry that everybody is on board, because at the end of the day, we would wish this policy to be implemented. It is not our document. It is a policy directive we are giving, and the joy of the ministry is to see that this policy at the end of the day takes life and is implemented. So it will be shooting ourselves on the foot if by any chance, then we can do it to the exclusion of the key players. And definitely service delivery is a function that is squarely on the shoulders of the counties and the county governments. So that one we are very much aware, and we are awake to that. And that is why any policy that we develop, it takes a process. And we do have a very standard way of doing a policy development. It is guided and it is ISO certified in the way we do it from one procedure to another, include the involvement of everybody and all the stakeholders that usually count. And the counties are very major core owners of these policies when you develop them. So say that the counties are not involved or consulted is not correct, and I want to dispel that very clearly, and the evidence actually points to the contrary. Now, that said, the counties, when we develop a policy, okay, for the country, then the process is very elaborate of making sure that we disseminate it also to the counties. Although they participate in the preparation of the policy, then it's also our mandate to make sure that it is disseminated across the counties. Now, this may not happen in one go, because we do have 47 counties. We do have, of course, we do not have unlimited, human resource, for health and also capacity to be able to do everything in a flash. So we usually do it in a very organized and sequential way, and sometimes a message may get to one county a little bit earlier than the other, and this may be what could be causing what you see as some of miscommunication that are happening.
Okay.
But service to say that we are able to reach each and every corner of the country, and we are working in collaboration, and the counties are part and parcel of the process that we do.
Okay, now Angela, you are shaking your head in disagreement. Why?
Well, it's because I think we live in a country that over time is known for processes. I think we proud ourselves of having first one of the most progressive constitutions. We pride ourselves to having, as a country, with some of the most progressive guidelines and policies in place. But as Nerima quite rightly put, most of these are lying in Afia House or are lying in these big offices. It's so interesting when I listen to Dr. Kaliti, and with all due respect, Dr. Kaliti, there are many health workers in this country today that do not even know that the RMNCH guidelines for COVID were actually released. There are actually health workers who do not even know what they are supposed to do, yet the protocols were released by WHO and they were supposed to be adapted by countries. So when I listen to Dr. Kaliti and relate to that, what I hear from my citizens when I go to the ground and from the health workers on ground is totally different. The question I have, and I have this for the Minister of Health and another player in the government, is how comes the outcomes, the reproductive maternal health outcomes, like the story that Eunice just ran, how comes they are not responsive to what we've just heard, that everything was disseminated? No. Some of those policies have never left Afia House, for example. So we cannot really say that the policies are developed and we are always reviewing and revising. But how they trickle down to actually be translated, including budgets that are responsive and that actually can take up those programs and actually support them, they are lacking. And so I think it's important, Gladys, at this moment as a country, we introspect and ask ourselves, how comes, leave alone COVID, even in normal circumstances, how comes we have still never reduced maternal mortality? Why has the reduction been so slow? So we really need to ask ourselves, and I think that now brings us to the other aspect of it. Maternal newborn health, it's a multisectoral action. And I think as we saw at the start of COVID, and even as we continue seeing the progress going on, there were sectors that came to play. The local administration was a clear sector during the curfew time. They played a role in either stopping women from going to the health facility or making women decide whether they are going to the health facility. They played, the road ministry plays a role in, are those roads accessible at night? The transport sector. There's so many, the education, what is the level of empowerment? Health literacy, primary health care, prevention and promotion plays a very key role in health and reproductive health. So until we are able to look at maternal health care as a holistic aspect, I think we'll continue seeing reversing the gains as we're seeing. And so it's a country, and as we take stock of the Constitution 10 years later, this is when we are taking stock, we should ask ourselves, health is a basic human right. Why is it a privilege to most of the women and girls in this country? Why are still marginalized and vulnerable populations, adolescents, people, women, disabilities, even the common woman living in some marginal, why are they not able to enjoy that? And I think as we say that, and as we look at that, let's take back 2 years ago. In 2018, the Ministry of Health released a confidential inquiry into maternal deaths in this country that spoke to the fact that 9 out of 10 women in this country are dying of poor quality of care. That is 2018. COVID was not here. Why is that? Why is the reason? So we need to look at ourselves critically and ask ourselves, what is the missing link? Where have we gone wrong? Instead of being defensive, how can we come together as sectors? How can we come together as stakeholders with a key role to play? With the citizen at the center in front of it, because those are the consumers, and ask ourselves, when did the rain start beating us and what needs to be done?
Okay, and speaking about some of the impact of some of the regulations that were put in place to deter COVID-19, George, when the health workers are on the ground and we have things to deal with in terms of curfews, there was a time we were dealing with the cessation of movement. How did that translate to the access to maternal health services?
I think this is information that is in the public domain, that when the curfew was pronounced, especially the initial stages, the first phase of the curfew, there was fear and dreadfulness of the people being out in the night. And many people hold back at home in the evening, including the pregnant and the mothers that were expecting to give deliveries at the hours of the night. So many could not go out because there was fear, and of course the experiences that were outside there on the brutal action of the security forces that were providing surveillance on curfew. People were not respected irrespective of reasons that they were out in the night. And so whether you were pregnant, going to the hospital, feeling that you are going for deliveries, people decided to remain at home. At that time, many pregnancies that occurred in the hands of unskilled professionals ended up with very poor outcomes. And that is where you hear of the drop of the services, access to services of maternal and child health care at the facilities. So the impact was huge and very, very bad to the community members. However, in the second phase, when the curfew was extended, mothers could be sensitive to start off trooping to the facilities. But again, you see at the facility level where they should access the services, the healthcare workers have their time of leaving the jobs, and those who work at night were not also adequately prepared to receive these cases, except for the level 4 health facilities where we have more staff. But the dispensaries and the health facility, health center levels, where the staff levels are low, the services at night, when most mothers give birth, was really affected. And therefore, we have seen that level of the impact of the COVID on the lives of mothers and maternal and child health, because of accessibility of the services and also because of the government regulations that did not provide adequate guidelines at the initial stages on how to assess and triage those who are working in the night for various specific reasons.
Okay.
So that impact was there.
All right, Dr. Kaliti, as George says, this is information in the public domain. How are you working in conjunction with the Ministry of Interior to ensure that we do not stop any of these women accessing these services, whatever time of the day?
Thank you. I totally agree. That is one of the major challenges we faced initially when during lockdown and curfews, then women suffered because unfortunately, labor and pregnancy does not know about time of the day or night, and the baby can decide to come any time of the day or of the night. And when this came up as one of the major challenges in the early months of March, April through May, one of the first things that we did at the national level was to contact our counterparts in the interior, ministry, and we used the chiefs and the sub-chiefs and the village headmen to make sure that women who were caught up in such a scenario are facilitated to access hospitals. And we did that across the country. Of course, there are a few very innovative innovations that came up within selected, there are no limited facilities like in urban centers where we had the Wheels for Life, try to give a hand on that. But across the country generally, the generic move that we took as a government was to make sure that we involve the security forces so that women who face emergencies during curfews or lockdown are not only exempted, but they're facilitated to be able to access services at the earliest opportunity and within the nearest facility that they are. The other thing we also did was to be able sort of to advise across the country and restructure that we limit cross-border, where border is in quotes, not the national borders, but from one location to another in terms of accessible facilities, so that we encourage women and the Kenyans to use the facilities that are nearest to them for obvious reasons that you minimize the risk of transferring infection from one place to another. And when you're within the same vicinity where you are, you share a common risk profile when it comes to infectious diseases like COVID-19 in this case. And those are some of the restructurings that I think could have done a good deal in sort of mitigating some of the impacts that we are seeing. And for Helen and my colleague, I totally agree with you. You are doing a very good job because you must be able to be a very strong advocate for maternal health. And for White Ribbon Alliance, we recognize you for that. That is a job you need to keep up going so that you can keep the spotlight focused where we need to act. But service to say that, and I can share, we do have the data with you, there are definitely isolated cases where we have had those outcomes that you're talking about, and we're on top of it, and we're addressing that as a ministry together with everybody else. But generally, I can say for sure, we had a dip in March to April of 30% in terms of utilization of services. But by the time we were hitting July, I can confirm to you that the data is speaking otherwise, that the utilization is actually at par. In fact, it was a little bit higher by 15%. And that's why we are shifting our focus to quality of care within those facilities, because it is our hope that it is not just enough to go to a facility, but it is more important to be able to get the right quality of care that you need. And I'm happy to announce that, to let you know, as you might be aware, that Kenya is actually part of the Quality of Care Global Network, and it is led by none other than Her Excellency the First Lady, who is actually a member of that Quality of Care Network, specifically for maternal health. And I think it's a golden opportunity that we need to move to be able to reshape and focus on the quality of care. And quality, of course, has different dimensions. It has an issue of time. It has an issue of human resource and the right skill to be able to get there. It may not work overnight, but definitely is the right step that we are putting quality of care at the center of our intervention when it comes to maternal and reproductive and newborn health. And we need to be able to realize that as a country. It is a commitment that also as citizens, we want you to be demanding that from the healthcare providers so that you can also push the system to be able to give you the highest level and the highest quality of care that you actually deserve rightly.
And when we talk about the quality of the healthcare, there has been concern that even the healthcare workers are afraid for their own lives because they are not well equipped to not only protect themselves from contracting the virus, but also catering for these mothers that need their services. Narima, what is your experience?
Thank you for the question, Gladys. With healthcare workers, I think we can pull back to a story a few months ago where a clinical officer was shot in Kericho County during curfew hours. We've conducted a number of surveys with healthcare workers who have indicated not just fear because of the curfew hours problem, but also a lack of understanding of where we're going as a country with the pandemic response. So key issues being access to protective equipment, PPEs, access to information, critical information to secure their health, access to health insurance, access to isolation facilities. For most healthcare workers, nurses, doctors, clinical officers, these are not taken care of consistently. So even with what's being brought into the country, they're not even sure where the dissemination plan is, when it's going to get to their facility, how they'll be able to access these things. If they get infected, they have to isolate. They don't necessarily have insurance to ensure that they can actually access services, health services themselves, and protect their families. And where would they be required to isolate? Where are they supposed to, if you're running a COVID-19 ward, supposed to live for the period of time that you are running that ward? Do they have disaggregated accommodation facilities for men and for women? So these are some of the key questions that have been asked, and we've already seen a number of healthcare workers that have been infected by COVID-19 with very little response from the government. We have written over 16 letters to the Ministry of Health between March and June, 16 letters. And some of these questions we asked them: how many PPEs do you have? How many facilities are COVID-19 facilities? How many healthcare workers do we have? How many units do we have with a healthcare worker where you have a doctor, anesthesiologist, a nurse? How many of these things do we have as a country in terms of the state of preparedness? And we haven't gotten to these questions. And it is September, going to court to ask for answers to these questions. And the Ministry of Health, through the Attorney General's office, has not responded, not to the letters that we sent or to our petition in court. It's already September. We are 6 months into the pandemic. So I think, as Angela has said, yes, I think we have made strides. The RMNH policy during the COVID-19 was a good stride by the Ministry of Health. Its dissemination hasn't gone as well, and it's fine to admit that. Similarly, we've made strides with healthcare workers. However, there are still a lot of concerns. So unless we can decide to work together to address these concerns, we're going to start to lose a lot of the gains that we need in maternal health, a lot of the gains that we need in newborn health. We're going to have a drop in vaccinations, which means we'll have more pandemics to address in future in terms of either polio, tetanus, or anything else that we can vaccinate and take care of at this stage, which we will not unless we are honest about the fact that there are gaps in the response in Kenya. There's gaps in the information being provided to the public, and the Ministry of Health and county governments are not speaking consistently.
Okay, and George, the fear of executing the mandate, especially when you talk about midwives, the community health workers, because they don't have protective gear, has been real also in the counties. Talk about that.
Thank you very much, Gladys. It is true that protective gears is not very much understood how to use at the household level. This is because of the fear of the community health workers to move into the household the way they usually do, to provide education on how to respond to the COVID pandemic in the country. Because when people were alerted on social distancing and the use of the protective equipment, personal equipment like gloves and the masks, access to these equipment at the community level has been a tall order, because many masquerade as hawkers of these facilities or equipment, but the quality of this equipment is not really known. So you find people buy them in the open air, and that means the quality is not really understood. Then the community health workers, when they want to go to the household, they need to put on this personal protective equipment. Gladys, I want to tell you one of the personal experience in the community. Personally, I was locked down when I went over the weekend, and then the lockdown was announced. I worked from home for about 2.5 months, and I interacted with the community and the community health workers. The chiefs or provincial administration and the community worker did a great deal in terms of sensitization of the people about the COVID pandemic. But the challenge was access to this personal protective equipment. They were not there. And where they were, the household level did not have the quality ones, because you hear somebody sharing. They buy one because of the level of knowledge and poverty, and want to share this one. But again, when the community health workers move to the households and to the community, especially households, when they put on the gloves or they put on the masks, some of the households that have no much information fear them, thinking that they bring a coronavirus at home. So access to the household was compromised. But as we increasingly move through effective mobilization and sensitization, we have seen quite a big improvement in terms of the attitude, that people are becoming very receptive, and therefore the access to the households has increased by community health workers. However, we could report still that reluctancy by the government in terms of putting pressure for people to sustain observing the protocols that have been put in place by the government on the pandemic is being experienced, and people are falling back to the old practice and thinking it is now normal and not new normal.
Okay, now, Dr. Kaliti, it is clear the trickle-down effect of some of these issues we're talking about. A lack of PPEs means the midwives and the community health volunteers will not be able to do their job as they should. And of course, those that are mandated to do the same in the healthcare facilities. How are you addressing this?
Well, thank you, Ogwele, and thank you for this question. That is very pertinent. But I need us to just set the record straight a little bit when it comes to PPE. You know, when you are using protective equipment and in COVID-19 and even in any other infectious condition, then this PPE is usually tired. As in it is in tiers depending on the cadre of personnel that you're using. What you require at the home is very different from what you require in a theater setting, which is the highest level sort of in such a setting. And this PPE, again, we did not have unlimited resources as a country, as a public, as a government, and there's of course prioritization. And Ogwell knows very well that community health workers, their nature, we do have a very clear, elaborate mandate of what they do, but the elementary, whatever they need to do within the community, is very basic, and that's a basic attribute of PPE. Unfortunately, we had a few cases earlier on where we have a community health workers, and Ogwell and colleagues, you are also partly part of this. You were demanding for PPEs that are not appropriate for the task that was being given. And let me say this, because the community and within the household, we basically do promotive and preventive services. We do not do curative services within the community because we do not have the infrastructure, we do not have the capacity, we do not have the resources even if we wanted, not at this time. So basically, when you want to say that you have a community health worker who is going into a household equipped like a person who is working in a hospital, then it raises questions on what exactly it is and if we get it right on what our roles are. That said, and especially for maternal health, which is very pertinent here, let me make it very clear that the only place that we know that can safeguard the interests of the mother and the newborn is being delivered within a facility by a skilled person. Why do I say that? Because I hear this narrative of home delivery is coming in and on, but let me say that it should not be encouraged at one time and should be discouraged very strongly, because a pregnancy can go either way within a very short time, and you are not sure that a pregnancy is normal until the delivery process is over. And there are many mothers who have gone to a facility or to a delivery, they're very okay, and within a space of 30 minutes, everybody is running around town to try to save the life of that mother and that baby. And for that reason, the home environment can never and has never been ready to conduct a delivery. Not at this time, not in the near future, and we need to emphasize that. So the effort here should have been, and we did that as a government, the priority was number one, make sure that we equip the healthcare providers within the facilities who carry the highest risk. And of course, we may not be able to do that at 100% and at the speed that is usually necessary because of a few issues here and there that are in public domain here and there. But service to say that we did that in a structured way, and I think by the time we are talking about accessing PPEs for the community, we had covered a good ground of the facilities. And again, the PPEs for the community health workers is very limited according to the scope of what they're supposed to be doing, which is basically sensitizing women, mobilizing them to be able to utilize services as is needed, and doing the very basic in terms as it aligns to our UHC model. Because we have adopted as a country, we have chosen that to go for primary healthcare as our UHC model. So that speaks volumes on what is expected in each area. So we need to have that clarity so that when you're talking about PPEs, we know what exactly we are talking about, and we'll be able to facilitate those. Because if we put all our money in the wrong PPEs, then we deny the people who actually need the PPEs, and then the time comes.
Dr. Kaliti, I think at this point, the community health volunteers play a huge role. And in this point, even George mentioned they just need masks, gloves, so that they can also, you know, tell the people that we are safe, so we can actually cater for you. Ngoko, you were shaking your head when Kaliti was talking about this. What's your comment?
You see, Gladys, you and me know that Kenya is a country with very limited health workers. Whether they are midwives, nurses, doctors and all that, Kenya is a country where we keep on seeing health workers strike. There are reasons as to why. And I think one of them is because of poor working conditions. And of course, poor working conditions, including some of these things that George was talking about, PPEs. But we also know that the backbone of healthcare, the frontline healthcare in this country is borne by community health volunteers. I would love to use the name community health workers. But since they are not even given anything, they work as volunteers for their communities. Let's just call them community health volunteers until that moment that we can be able to embrace them and actually take them in as community health workers, because they also have their needs. But the fact remains is that for this sensitization to take place, for this literacy to reach the communities, they are the ones who have been moving from place to place. They will need masks, they will need surgical, gloves, not surgical gloves, but gloves. They will need protective gear. There are people coming from communities, moving from one household to the other. So they need to be protected. So we can't say that we cannot think about them. Yes, we need to think about them as primary healthcare, preventive and promotive healthcare workers at the end of the day. Well, we all know that what is propagated now is let women deliver in health facilities. But the role of community health workers cannot be underscored, because they're the ones who will remind the women when to go to health facility. They'll teach them on self-care. They'll teach them on this is what you need to do, because our health system cannot be able to do all that. We already have very a limited number of health workers, so that cannot. So in the COVID response, what I say and what I keep on saying was missed from the word go, and I've really not seen that uptake. When we talk about the response and the task force, we should have borne into consideration who are the key players who should have been part and parcel of the task force to keep on informing and giving information to the Minister of Health who was leading the response in ensuring that all this that we're talking about, not just maternal health, but also other sectors that were left out. Where were the community health workers? Who was representing them in the Ministry of Health? Where were the citizens, the players, the key stakeholders, those who are supposed to be the consumers? Where were the other social workers, for example? All we saw was the top cream. There were epidemiologists, there were microbiologists and the like. But where were the other players? Where were the civil society? They are supposed to be part and parcel. And I'm not just talking about INGOs. I'm also talking about grassroots, because that is where the action is. Where were they in the response? And why have they not taken up? Why have they not been? Why has the response not picked up all these people? So let's be realistic. Let's acknowledge it's a country. Yes, it's a pandemic. It came, it struck us. We have not been picking lessons. We've not been listening. Listen to what Nerima talked about. I'm so glad, because we work with Kelin and other CSOs in the COVID response, the right to health response. We've taken written statements, we petitioned, we've done so much, but we never get the response. We even engaged Dr. Amodi and asked the DG some of the questions, and some of the answers we're getting were like, okay, should we go to the Council of Governors? Should we go to the health workers on the ground? Let's go to the health workers. Most of them do not have the protocols and the guidelines. They are like, yes, they come to us. We do not know whether they have COVID. Even when they have suspected symptoms, we don't know how to respond, because we have not been trained on how to handle a pregnant mother who has the symptoms. So let's appreciate that as a country and learn that we have had so many near misses, but we need to learn and move as we go along. Let's embrace much more, because we have so many players who are playing a role in ensuring that health in this country is really improved. But until we can be able to be all inclusive and embrace, we cannot move.
Okay, Dr. Kaliti, before I take a quick break here, I think there is communication, there is a need to have your ear on the ground so that you can get the feedback as it is on the ground. Are you working with the county governments to ensure that they give you the right feedback? Because clearly there are gaps you're not aware about.
Yes, let me clarify that. We are working with the counties, and maybe Angela is not privy, and you may not be privy because you are maybe not part of the bigger system of governance. But just to let you know that for each and every whether you call it a sub-county, we do have a structure and person who is actually nominated by the county in the form of reproductive health coordinator, one says to the county director of health and all that, within each of these 47 counties. And these are people we talk to on a daily basis across the country. And this information, in fact, when we developed the guidelines, and I wish you could go back to the clip that you played initially, where we have Anissa Omar from Kilifi was encouraging women to come. If you notice, she was actually holding this book in her hand, just to tell you, and that was in Kilifi, and that was way back in April. That tells you a lot on itself. Now, that said, where are the community health volunteers, where are the community health workers? Just to let you know that we do have a very elaborate strategy of community health workers, and in fact, the government went flat out within the ministry, and we trained very many of them. In fact, we are even we overshot our target of the community health volunteers that were supposed to have been trained within the first 2 months in terms of COVID-19 response, and being able to mobilize the community health units, which will be the focal points for our entry to universal health coverage. So definitely community health volunteers, community health workers are at the center of the response of the ministry, no question about that. That said, we are definitely in touch with the county, and we have mechanisms that we have, and we even have an entire department that is just starts with just making sure that we have correct intergovernmental relations and communication between the national government and the Ministry of Health and the county health departments and the county government.
Dr. Kaliti, is there leeway to involve other stakeholders outside that purview that are part and parcel of maternal health care?
Absolutely, absolutely. There is a lot of leeway. And in fact, the message we are saying that please, if you want to play a part, come join us. We do have a stakeholder engagement, and we also have a very elaborate framework of engaging with partners and players like Kelly, who are in this room, and White Ribbon Alliance. And Evangela can be honest, we have engaged in very many ways. We have involved in very many ways. But as usual, and I commend you for that. It is good to be vocal and make sure you vocalize and you advocate for what you stand for, which is very important.
Okay.
But the truth be said that we have been engaging, and we engage, and our doors are very open, and we cannot do it alone. As I said, health is a collaborative, multi-sector, approach, and it is not a Ministry of Health affair. It's not a national government affair alone. It is not a county affair alone. It is an affair for everybody who has a heart to play a role in improving the health of each and every Kenyan, and they are all welcome.
All right. Dr. Kaliti, we'll come back after this short break because we are all staring in the face of that strike that health workers across the country are downing their tools. What does that mean for maternal health care and healthcare in general? We'll come back to that in a moment. Stay with us.
Top dressing tips. Top dressing is the application of fertilizers to boost harvest in growth period. Ensure the soil is moist, and in warm weather, ensure you mulch to avoid evaporation.
More than 500,000 farmers in Kenya can have easy access at affordable packs of 1 kg to 50 kg across major agro-dealers. Farmers who have used Mavuno fertilizers have realized 30% more yield. Please feed your crop and soil with the best fertilizers for future prosperity. Call us today and learn how Mavuno fertilizers is helping in increasing food production in Africa.
quality KEBS certified steel. TMT steel bars, produced from the most modern machines and technology, reliable and with the highest strength, suitable for all types of construction. That is, high-rise buildings, bridges, houses and roads.
Look for the Devki mark on a wider selling reinforcement, twisted and TMT rebars, which are KBS certified and have the diamond mark of quality. Devki Steel, Kenya's most trusted steel company.
It's time to kickstart your smart and give your brain a mega boost with DSTV. There's oodles of mind-blowing channels for kids young all together now. To get your knowledge workout, get connected to DSTV.
Thank you for staying with Your World. My name is Gladys Gachanja as we take stock of reproductive health and, of course, maternal health in the country in the face of a pandemic. Now, before we get back to the conversation, the business of childbirth in many Luhya communities has been the preserve of women only, with their husbands and fathers keeping off from the early stages of pregnancy to delivery and nursing. This is, however, changing with the introduction of father-to-father programs that encourage men to be active during the journey to childbirth. Zacchaeus Musame with more.
Our mission started off at a Sabwali village in Emhaya constituency, Vihiga County. Here, we meet 26-year-old Bernard Munala. Bernard and his wife, Trufosa Nyakoa, have been on the forefront of championing for the Anzilisha Baba program, which supports maternal and child health care.
Ikiwa ni kupeleka mtoto kliniki, wewe usipokuwa kipaumbele kutangulia kuambia mama inafaa tupeleke mtoto kliniki, pia yatakuwa chini yako, atakaa tu. Sasa inafaa wewe kama mzazi ukue mbele kuambia mama iko hivi iko hivi. Kitambo ndio ilikuanga haya maneno yalikuwa yameachiwa wa mama, lakini tangu Anzilisha ianze ilitueleza ikatuambia ambapo baba una majukumu fulani ambapo inafaa utekeleze ili mama akue nyuma yako.
Under this program, father-to-father groups mainly consisting of young fathers and aspiring fathers are given information on good maternal and child health care. The groups are empowered to spread information and support mothers in the community.
We are focusing now on what we call domestic resource mobilization, so that we are able to sustain the programs and the counties are able to own it because they are part of it.
Following worrying indicators on maternal and child health care in 2017, there was need to come up with a strategy to boost low coverage of skilled delivery, low coverage of first and fourth antenatal clinics, and low coverage of IFAS intake that contributes to anemia and low birth weights. It is in this regard that community health volunteers in Luanda and Emhaya constituencies were tasked to come up with father-to-father and mother-to-mother groups which would help create awareness on maternal health issues. Luanda sub-county in Vihiga County has started to establish groups, with the Kwanda group being the most vibrant.
Peleka mtoto clinic huwa tunapelekanga naye. Anasaidia kubeba mtoto hadi clinic. Kupika na pika, huwa anasaidia kupika.
When the mother is pregnant, during time of delivery, the mother just comes to the facility, maybe accompanied by the mother-in-law. We want the owner of the baby to accompany the mother to the facility. Why? Because there is sometimes that need where we need you to help us, even with talking to the mother. You know, labor is not an easy thing.
Tangu nijiunge safari imekuwa mzuri. Tunashirikiana hata na mume wangu. Pia venye alisikia alikuwa na furaha. Alinisaidia kwa kila nilikuwa namwambia, alikuwa ananisaidia. Hata jikoni ananisaidia, kama nimemwambia siwezi ananisaidia, anapika.
Despite the stigma towards men who have participated in the program, they have vowed to continue with the spirited fight, whose end result, they say, will be seeing men appreciate and understand the challenges pregnant women undergo.
The skill delivery, we were doing very poorly. Most mothers were not delivering in the facilities. They were delivering at home with the help of the traditional birth attendants. And just to mention, on this program, we also have an activity where we are turning the traditional birth attendants to birth companions. Instead of them delivering at that mama at home, this mama brings them to the facility for skill delivery.
Kuna hivyo vitabu ambao wamepeana, unajaribu kumsisitiza aendelee pia kusoma, akipata mafunzo zaidi pale ndani, wewe pia ukiendelea kumpatia ile guideline. Kusudi pia naye ataendelea kusoma akihimiza mke wake pia.
Mzee wangu aliingia kwa chama ya Father to Father. Tangu aingia hapo, nilikuwa na mimba. Alinishughulikia, kanipeleka OC kwenda kujifungua. Na kabla ya kwenda OC alikuwa ananisaidia kazi zote za nyumbani, kama kwenda mtoni, kufua, kupika, kuosha watoto. Alinishughulikia.
Imesaidia sana kureduce anemia, low birth weight standing, vifo vya kina mama wakizaa na watoto wakufa kabla ya miaka miwili. Hasa hawa kina baba katika zile vikundi vyao huwa wanaelimishana na wana encourage each other, na kila ambacho kinawafunga pamoja, kuna hata miradi wameanzisha to substitute on their own income.
The county government of Vihiga is looking forward to rolling out the program in the entire county with the aim of bettering maternal and child health care.
Hii program ilianzia Luanda sub-county, wakati ilianza kufaulu ikasonga Emuhaya sub-county, na hivi sasa tuna mipango ya kuiweka katika sub-county zote, Vihiga sub-county, Sabete sub-county na Hamisi sub-county. Hii program ni partnership kati ya Nutrition International ambayo inasapotiwa na Canadian government na county government of Vihiga.
Hawa baba walikuwa na nia fulani. Walikuwa naona kwamba huu mradi maybe kuna mapato ama nini. So tulipoendelea kujifundisha na hao ambao tulikuwa nao, kuna wababa kadhaa ambao walifaidika.
The success of Anzilisha program in Luanda constituency at its pilot stage here in Vihiga County has seen the improvement of skill delivery from below 50% to slightly above 70%. The program, which will be rolled out in July in the entire county, aims at improving the healthcare of mother and child in the county. Zakis Masame, NTV, Vihiga.
A great report there by Zacchaeus Musame, affirming the role of community health volunteers, but also the importance of safeguarding maternal health. Before we get back to the discussion, we had asked you on the question of the day, what is the biggest challenge in accessing maternal health care services during the pandemic where you are? Let us know. Hashtag New Normal. Kipiegon says the evolution has killed healthcare. No drugs at the health centers and dispensaries. Numerous health workers strike. Poor accessibility. Another from Ken Odanga, who says most health issues are more of just corruption. Can we hear you? Do we have another? The Wajir Pundit says delivery services. Well, are you accessing it, or is this the challenge? I guess that's the challenge. Ado Abdul says women shy off delivering in hospitals, which causes babies to die. There is a possibility of that happening if you don't have a skilled attendant. Do we have any more? Okay, for now. Samson Armstrong says transportation network is still a big challenge in Nyamira County, and we'll definitely keep sampling your comments and your challenges even as you talk to us on that hashtag New Normal. Now, Angela, we are, as somebody has just mentioned, facing imminent strikes across the country. Some counties have already downed their tools. Are you surprised we got here?
Well, I'm not surprised, really. I think that has been the norm, right? I don't know whether there's a year that has gone without a strike from health workers. And what shocks me is that I don't think we take that seriously. And what health workers are asking for is, first, they are human beings. They are Kenyans with rights, right? Mm-hmm. They are human beings, so they need to feel protected. They need to feel appreciated. They need to feel that they are working in a place where they are not going to get sick or get into occupational hazards because of being healthcare workers. At the front line, they are putting their lives at the front line of the rest of the Kenyans, the over 50 million Kenyans. So, excuse me. So at the end of the day, we need to think about them. And more to that, we need to listen to them. We need to listen to their needs. Speaking to a few of the healthcare workers, and as a healthcare worker, I know that even during my training days that you need to work in a place where you feel secure. You need to work in a place, for example, if I'm delivering a mother and she needs blood, surely I don't need to go to my colleague and ask, can we get blood, because we do not have a blood bank where we can store blood. Can we really get blood or source for blood, or can we get something out of our pockets to pay for this mother? Mm-hmm. I need to work in a place, or health workers need to work in a place where they feel comfortable. And what annoys me a lot of times when I listen to these healthcare workers strikes is the way the narrative that is pushed, that healthcare workers are demanding more pay. A lot of times it's not even about the pay, it's about a working environment that is conducive, not just for the health worker, but also for the patient. Because at the end of the day, it's quality care. We can give health care, but if that care is not quality, surely we will even do more damage than good. So at the end of the day, I think it's important that the county government and the central government and other stakeholders who are involved sit down and ask themselves, where is the missing link? And I don't want to leave that only at the premise of healthcare workers alone. You as a Kenyan, you have a right to quality healthcare. I keep on saying I hate the statement Serikali's idea. That puts us in a place where you feel so apathetic. Health is not a privilege. Health is a human right. We have taxpayers who are supposed to be receiving services because of the tax that we pay. So at the end of the day, we should be working and supporting our healthcare workers to deliver. So a lot of times you hear our healthcare workers are demanding. We are the ones who actually fault them. But we sit back and ask ourselves, what are they saying? And why are they saying that? At the end of the day, it's because they want to see the best, giving the best to the citizens. So we need to listen. We need to ask ourselves, surely this pandemic has already showcased how much of healthcare workers are exposed. We have many who have been on quarantine, isolation, many have died. What are we doing? Are we not taking stock and asking ourselves, where is the problem? And what do we need to do to avert the strike?
And speaking of the effects of a strike, this will have a direct impact on the maternal healthcare in this country. George, you have been part and parcel of this space for a while. You've seen the impact of strikes before. What do we expect, especially in the face of a pandemic?
Strikes by the healthcare workers in the country has been, I would say it is something that they are getting used to, because they have a right to demand for their basic rights from the employer. And the employer sometimes, in most cases, they complain of the bloated workforce, I would think so. But I think it is about planning. If there is adequate planning, allocation of resources, if that is sufficient to take care of the workforce, then we will not be able to look at the challenges of continuous threats of strikes. The environment. The environment has really been compromised where the healthcare workers provide these important health services. And that brings the attention of the healthcare workers to fear for their own health in their working environment, and two, to fail their obligation to provide the services when the people they are supposed to serve, the citizens, have come for these services, and then you have to refer them a long distance, maybe to the next level, because you don't have adequate facilities to provide these services. And therefore, that was the reason why community health strategy was brought on the space, to bring the linkage by mobilizing the communities to seek the services. And then the government's obligation was to provide the environment where these services could be accessed and availed. But we are still struggling because, as I talk to you today, we are in the third phase of writing the community health strategy. And we are still struggling with providing adequate health facilities in terms of equipment, in terms of the health workforce, and in terms of the services that they should get at the facility level. You hear of stock out of medicines and commodities at KEMSA, and you hear of many other challenges that affect the population on access to health. And therefore, that places the community at a very awkward position to take make decisions at home, which sometimes are not very good in terms of quality of healthcare. That is why you find so many clinics that are opened in the rural settings or in the back streets that are not properly providing the standards of quality of care. Mm-hmm. And those services compromise the health of the people because the regulations are not observed, the standards are not observed, and those who are providing services are not fully trained, because you find that those who open these services, sometimes they open them because of they want to do business. But business with health sometimes is very dangerous, because health is a good that must be protected, and it is protected by law, but it is a right for every population to access it. Thank you.
Okay, and Nerima, some of the healthcare workers have said they are downing their tools because they think this focus was actually shifted to COVID-19 and forgot other ailments and other needs within the healthcare. What is your comment on that?
Gladys, that is for me?
For Nerima.
Okay, sorry.
Thanks, Gladys. Yes, so there's a number of issues that have been raised by healthcare workers in terms of them downing their tools, and this has been a continuous struggle since 2016 when we had one of the first major doctor strikes. But as Gladys has mentioned, this is a continuous struggle that hasn't been addressed. But in terms of a shift of focus and resources, we can bring us back to the conversation on maternal health, and this has been a concern from the beginning of the pandemic. And I did mention that Kenya did take a good step in terms of having a policy on how to guarantee essential services during the pandemic, particularly maternal health services. However, as I said, this was at Afia House and hasn't trickled down. So it's quite obvious from what the healthcare workers are experiencing, there's a number of issues coming from the communities, in that one, there's not enough information on how to access healthcare services. Even though they might be available, how to access them is not information that's been made available to the communities. So I might not go to the hospital because I don't know I can. Mm-hmm. And then if I don't, then I might be giving birth at home. The next thing is there has been stockouts in commodities, including contraceptive commodities and other reproductive health commodities. And then finally, healthcare workers themselves, even though they would want to shift resources towards COVID-19, even though they wouldn't want to, they're not guaranteed of the health and safety within their facilities. So there has been some people who have been turned away as a result of this. So this complete diversion of resources is contrary to the policy by the Ministry of Health. And it does speak to what we've been saying. There are policies in place. There is the RMNH policy by the Ministry of Health during COVID-19. There's a Health Act 2017 which guarantees free and compulsory maternity care. Mm-hmm. There's a constitution which guarantees the right of access to reproductive health care services. These are there and they're in place. However, them turning into reality for women and girls being able to access services hasn't translated. Mm-hmm. And this is because we've seen this historically from 2016. The policy will come from the national government or from the executive and not go to the primary caregivers, which is the county governments, of the obligation to provide the services. And while Dr. Kaliti has said that they speak consistently and they do engage county governments in making policies, this is not a reality for Kenyans. So the question is, if you are speaking and the county governments do know, then who has dropped the ball?
Good
question.
Is
it the country or the national government? And when we're quite clear, there's instances where the national government has dropped the ball. But the 2016 directive, they didn't actually then transfer funds to counties that would ensure they can provide free maternity services, which is why many women still have to pay for maternity services today, despite this having been a directive in 2016. So I think it's time to be honest to see where is there a problem in the policy making that we're not seeing it translating to improve lives and health of Kenyans.
Dr. Kaliti, that is a good question to start with. Who is dropping the ball? Because clearly you seem to say there are all these structures put in place, but if the health workers are downing their tools, there is a huge gap. Who's dropping the ball?
Let me maybe go a little bit back, but also acknowledge that the issue of human resource for health is something that is much bigger than I am, and there are officers that are very capable that are handling that way beyond me. So I can only respond from the limited perspective that I might have when it comes to human resource for health. But service to say that ever since we had devolution of health services, we have had consistent strike. And if you look at the narrative and historically what has happened before, is that as a nation, we devolved a very essential and crucial part of our service, and that is the health service. Just the same thing, the same way you would usually take the security, forces and all that. Health is very critical and very essential. And of course, we are learning. Devolution is a brilliant thing, and there's no turning back. We all appreciate that, and it has definitely brought a lot of gains. But one of the things that we did, especially when it comes to human resource for health and the framework for that, we sort of went ahead of ourselves, and we devolved before the systems were up and running to be able to support smoothness and sort of a continuity of services, especially within the healthcare workforce. And we saw that a lot, with a lot of frequent strikes that came in after devolution. For the first 3 years, we have downy tools, left, right, and center, because some functions were sent to the counties, but others were shared at the national level, and there was a little bit of disconnect. However, we are learning a lot, and I'm sure you have had a lot of discussions that are going on around the Health Act revisions and the Health Service Commission. All those are geared towards curing some of these issues that you are seeing. But it is not a one-man show, as I said. I wouldn't say that one person along the way dropped the ball. All I can say is that there's a lot of learning to be done, and I usually say that a satisfied and happy healthcare provider who is enabled and is supported is a much safer provider for the patient. So
very well said, Dr. Kaliti.
Yes.
Let's talk about that falls in your purview. How are you going to safeguard the women of this country in as far as maternal health is concerned, even as we face another strike?
Now, it definitely a strike will fly right in the face of trying to improve maternal health outcomes, because we are depending on skilled care delivery and skilled attendants for us to be able to improve. And let me just say, why are women dying? Maybe before I answer you, Gladys, we may just look back and see why women are dying. And just to say that it's a little bit sad, because we are losing close to 6,000 women every year because of maternal health related complications. That's a very sad statistics. And I think it is sort of cause for national mourning. And why do I say that? Because in our settings, and not only in Kenya, but in many African settings, the woman is actually like the glue that holds the family together. When you lose a woman, you have lost a family, you're basically breaking the society, and you end up with a lot of vulnerable population upstream. And these are the children that we see there, and then also the outcomes of these children actually are affected adversely, because babies and children die shortly after the mother has died. And this is very sad. And this is a narrative that I wish was being run every day on the national TVs, so that we can actually ask ourselves very closely, and we sort of reflect on our inner self and answer a very simple question. What exactly is the value of a Kenyan woman? If we are able to answer that collectively as a nation, I think we'll be able to get very good answers. That said, causes of maternal deaths are known. Why do women die? Because of delays. The first delay happens at home when a decision has not been made. And that's why I'm happy with what is happening in Vihiga involving men, so that we can shift the balance of power, not exactly shift it, but sort of enable and allow women to be able to make decisions and be supported to make a decision that I need to go to hospital. That where most majority of deaths start occurring at that time, when you're supposed to go to hospital, but you're not enabled, you do not have the decision, you do not have the levels of power or the resources to be able to take you to a facility. Then once the decision is made, you need to access a facility, and that's why we're talking a lot about access. And these are the pillars that we have been addressing for the last 20 years, not only at a government level, but also at WHO and global level. And then finally, the third delay, when we are within a facility, now the issue of human resource for health and quality of care, time spent, and the kind of service you are going to get. These are the major causes, and they are known. The issue is now operationalizing them, like Angela is rightly saying, now translating that policy into real action and translation to the common woman who is pregnant in a far-flung area in Kenya. Now, those are the gaps that we have been trying to seal, and we need to seal like yesterday, and it's not something that can be done by one person. So as we face healthcare strike that is looming, my hope is that this will be resolved, of course, to safeguard the interests of the women, because pregnant women are the most vulnerable when it comes to healthcare system, and they carry, they take the heaviest flak when it comes to a broken health system. And of course, healthcare strike, healthcare strike is one of those dents that can very negatively, erode some of the gains that were made, and especially during this time of COVID-19. So it is my hope, my prayer, that we'll quickly reach a solution, and more important, we'll be able to prioritize, these issues so that they can be resolved in a manner that it does not translate and affect the common mwananchi, because they pay a very heavy price for that.
And speaking of which, unintended pregnancies resulting from reduced attendance of or uptake of contraception due to the fear of exposure to COVID-19 for those that go to health facilities to seek the same is real on the ground. Angela, speak on the same.
Well, I think the issue about unmet need for family planning has been, contraceptives has been ongoing, and it's actually now being exacerbated by COVID-19. And that already talks to the same issues that we are talking about. There has been, reproductive maternal health services were put on the back burner and the response, the COVID response. And that's why we are seeing what we are seeing now. Women want to space their babies, women want to delay pregnancy, but they are not able to do that because the service is not available. Either the health worker is not available or the service is not available. We've heard of issues about stockouts in health facilities. So if I go to a health facility, I should be able to trust my health facility such that when I go to a health facility, I should be able to get a health worker to attend to me if I need, first to give me all the whole convoy of whatever we call them of family planning services. And at the end of the day, that combo, I should be able to make informed choice based on the information I've been given, and then I choose. But if that is not lacking, I'll not go to the health facility again. And more to that, I'll spread rumors. I'll not spread, not rumors, but I tell my neighbors, don't bother going there. So I need to trust a health facility that I'll find whatever I need. And I think that speaks to a very important issue that I've had been discussed the last 2 months, the issue of the rising numbers of teenage pregnancy. First, let me correct that. I don't call them teenage pregnancy because we've seen girls as young as 8 years, 9 years getting pregnant. Those are below the teenage, so let's just call them right adolescent pregnancy. And there were a lot of solutions, and so many, there was an uproar and a lot of blame came to the Kenya Health Information System where the data was coming from. And that shocked me because, this is data coming from the government. Why are we even doubting it? That puts the question. Then, do we really use our data that we get over time? Because the data this year was actually less than what we had last year in the last 10 years. Do we really use our data for decision making, whether it is for contraceptive to be able to get enough, or whether to plan for these young girls who are getting pregnant? So I think for me, at the end of the day, can we be able to interrogate all that we're investing in? As a government, we invest in the health information system. Data is key in decision making, and not just data that is counted 1, 2, 3, but also data that is from experience. What are women and girls saying when they go to a health facility? I'll give you a very good reason as to why I'm saying that, Gladys. Last year, after realizing that we were losing many more women because of poor quality of care, we went on to a listening exercise. We went to ask women a simple question. What do you want? What does quality reproductive health care mean to you? And this was between girls between 15 to 50 years of that reproductive period. And we were shocked because I think what Dr. Kaliti is alluding to is very true. The fact that quality as defined by me as a health worker, by Dr. Kaliti as a policy maker, and other people is totally different from what women and girls told us. Women and girls told us that quality to them means when I go to a health facility, I want to be treated with respect. I want to be called by name. I want to find a smiling health worker who will call me by name and give me information. I don't want to find a nurse or a doctor who is in a rush and I'm treated like a just by the way. We want to find a health facility that is not dirty. I was really shocked, and this is something that I keep on talking everywhere, that women living with disability are not only marginalized but extra marginalized, because they told us, when I go to a health facility and I need a contraceptive, the first thing I'm asked, Why do you engage in those things and you have you already having other problems? Don't they have their reproductive rights? So when they go to a health facility to deliver, there's no delivery bed that is conducive for a woman who is living disability. When I am deaf and dumb and I go to a health facility, I do not find a health worker who can able to understand me. So at the end of the day, they are more neglected than other. So I think we need more and more to listen to what are the needs. Who is the person? Who defines quality at the end of the day? Is it just the supplier? Or is it even the consumer? So that at the end of the day, we can have that interface and that conversation and decide going forward, how does care need to look like? Otherwise, we'll continue supplying what is not needed, building more health facilities, putting very big CT scans, but they are not needed. Women lead simple things. Talk to me nicely. Welcome me. Open the clinic longer hours. I keep on asking, and I kept on asking them even in my training. Why is antenatal care clinic only open between 9 in the morning and 12? Do we ever take into consideration the needs of that woman, that she needs to go to the garden in the morning and she can actually go to the health facility in the afternoon? Who decides? Who shapes that? And that's why I'm talking about, it's important to bring everybody to the table. We are consumers of the care. As a woman and wherever you are, you are the, and the Constitution talks about public participation in shaping what needs to come out at the end of the day. So why can't we listen to the needs of these people before we can actually decide for them? This issue of experts for the long time has really not translated to health outcomes that are responsive to the needs of women and girls.
At that point, we need to take a short break right here on Your World. We'll be back with more.
Heaviness and a burning inside, it could be heartburn.
Indigestion and heartburn? Eno gets to work in 6 seconds and works on the 6 symptoms of heartburn so you can keep living life non-stop. Eno, fight heartburn and indigestion fast.
Dr. Rabbit, is that you?
Yes, it is!
Wow.
I see you're all ready for bed.
I'm supposed to brush my teeth.
That's right! You're really becoming a brushing pro.
Thanks. I have a good teacher.
We are Nation, Africa's independent media brand. We are committed to empowering all Africans, from the young to the old, from the curious to the educated, and from the heart of the cities to the rural areas. We are Nation. Join us, because if you want to get far, you do it together. Nation. Empower Africa.
It's my mole at the police station. They're already investigating what happened to Anna.
Darn it!
And we have another problem. That nurse, Nika Rivera. We already found her, but she got away from us.
Then we need to double our efforts to find that nurse, because I'm sure that my mom's hired men are doing their best to find her.
Hello?
I'm the nurse you've been looking for. I want to meet up with you. I'm going to help your fight against Senator Del Mundo.
Now's my chance to prove to everyone that I'm better than Anna.
Did you know there's a laundry bar soap that can help save you time, water, and money? You save by not having to use multiple products. And you only rinse once. For a laundry soap that can help save you time, water, and money, try Whitewash Extra. Brand power, helping you buy better.
to kickstart your smart and give your brain a mega boost with DSTV. There's oodles of mind-blowing channels for kids young all together now. To get your knowledge workout, get connected to DSTV.
It is your world. My name is Gladys Gachanja as we discuss the state of maternal healthcare in the country, especially in the face of the pandemic. Before we get back to that discussion, Argentine President Alberto Fernandez will fulfill an election pledge when he brings a bill before Congress aiming to legalize abortion, setting off the latest salvos in a debate that has bitterly divided the traditionally Catholic South American nation. Thousands of women sporting the green scarves that have become synonymous with the campaign for legalized abortion plan to descend on the streets of Buenos Aires in a bid to ensure the leftist leader keeps his promise. Likewise, anti-abortion campaigners, including Catholics and evangelicals, plan to demonstrate waving blue handkerchiefs to ensure the practice remains illegal. Mass pro-abortion rallies brought Buenos Aires to a standstill in 2018 when abortion was last debated in the Congress, but were not enough to sway the Conservative Senate, which rejected the bill after it had been passed by the lower house. Millions of children in war-torn Yemen could be pushed to the brink of starvation due to a lack of funding amid the coronavirus pandemic. The country's health system has all but collapsed since the war escalated in 2015 with the intervention of a Saudi-led military coalition to support the internationally recognized government against the Iran-backed Houthi rebels. A new UNICEF report warned of further deterioration of an already dire situation for children with the outbreak of the novel coronavirus. UNICEF quoted estimates from the Johns Hopkins Bloomberg School of Public Health that suggested an additional 6,600 children under the age of 5 could die over the next 6 months from preventable conditions. Elsewhere, veterinarians at Taipei Zoo have created several baby panda soft toys for new mom Yuan Yuan to help her maintain a maternal bond with her newborn baby, which has had to be kept in an incubator. Yuan Yuan, a giant panda gifted by China to Taiwan, was unable to nurse and feed her baby, which also suffered a minor back injury soon after birth. Their named cub, born on June the 28th, was the second baby born to Yuan Yuan, who earlier delivered a daughter, Yuan Zai, in 2013, the first giant panda born in Taiwan. The first pregnant woman in Liberia to test positive for coronavirus has given birth to a healthy baby girl. Sadia Mawolo, a nurse, contracted COVID-19 at work and was transferred to a coronavirus intensive care unit in a military hospital. Having recovered from the virus, she returned to give birth to a baby girl.
My greatest fear was my baby in my stomach. Because it came a time I could not even feel the movement because I knew very well that my baby had been very active. There was no OB doctor, no midwife, nothing was at the treatment center to even check me with my condition.
We moved in to the treatment center. We set up a maternity center at the treatment center. We ensured that midwives are available. And therefore, we provided all the support needed that in case Sadia went into labor, she could deliver safely in the treatment center.
I thank God I'm happy because every one of us that they took from here, we came back home safely, including the baby now in the stomach. So I'm very much happy.
The way they carrying out the mental hospital is symptomatic. So for her, if you get fever, they give you paracetamol, you get sore throat, they give you antibiotics. But you know, for a pregnant woman, you can't get certain medication you can't give to them in lack of sharing the baby. And you know, so how to manage it within the same context. First of all, as a sick person, and two, as a pregnant woman.
Now to an inspirational story. Meet Adriana Beramendi, a 24-year-old first-time mother who was born in Buenos Aires but raised in Salvador Maza, a town about 400 kilometers from the capital of the province of Salta and on the border with Bolivia, where she worked as a street vendor. Adriana Beramendi, who suffers from lupus and an immune disorder, became pregnant against all clinical recommendations. Her family, originally from Bolivia, helped her with treatment and prenatal care, but due to problems related to her Argentine identity card, she ended up traveling with her baby or her mother by bus to Buenos Aires. Having run out of money and sleeping in a shelter, she was referred to the Ramon Sada Maternity Hospital, where she gave birth prematurely at 31 weeks to 3 boys and a girl under scheduled cesarean during lockdown of the city. Hospital director Eduardo Valenti has said that it's very rare for a mother to get pregnant naturally with quadruplets, and even rarer for them to have all survived by being born with good weight. Back to a conversation of the day, taking stock of maternal health care in the country, and especially in the face of a pandemic. And speaking of which, George, the knockoff effect of the pandemic is that it has had adverse impact on our social economics, and this trickles down to the mother in the rural area. How does that look like, and what does that translate now to her maternal health?
Thank you very much, Gladys. As you're aware, the Minister of Health, in collaboration with the county governments, have put in place very good strategies on how to sensitize the mothers to access services in the hospitals. And they have been doing this very well in the past, and we have seen improvement in access to AMC services. Deliveries had been improved at the facility levels, and this was because of the awareness and preparation. Because women who are of childbearing when they were pregnant, the community health workers engaged them in conversations on how to prepare for skilled delivery at the facility levels. And therefore, they used to do a lot of what we call the savings at the family level in preparation for safe deliveries. And this could only occur as a result of engagement in income-generating activities, small-scale businesses, being in support groups where they do these savings. But the impact of the pandemic has brought this down. Most of the businesses do not pick up because of the low uptake of these businesses. Many people have run down in terms of their savings, and therefore you find that women are caught unaware when they are supposed to seek services when the time of their delivery comes. And that is compromising their intention and their plans to access quality deliveries at the health facilities. And this causes them to end up giving birth at home, as we said earlier, or using the cost-effective mechanisms for them, which is the option of using traditional birth attendants that they could access through the in-kind kind of payment. But at the health facilities, they have not been able to save for transport, because community level transfer to the facility requires the call for ambulatory services. And these services, either you have someone with a taxi that you can call, because you know the government transport system may not be very available and effective at the community level. So most of the time, the networks at the community is that they do their savings, they identify the taxi or transport service that would help them to rush them to the facilities when the need arises. But this has been since compromised by the pandemic of COVID in the country.
Okay.
And so the community and the households have this situation that they are facing today.
Okay, now, Angela, similarly, women with comorbidities, for example, HIV or hepatitis, are also at risk of getting, severe disease if they were to contract COVID-19, but also post-birth. This is bound to also create other complications. Talk about the importance of safeguarding the same.
I think, Gladys, as you rightfully said, when COVID struck, and I think not just in Kenya, it was already known that if you already had a comorbidity, it was very easy for you to contract the disease. And that meant that then anyone, not just even women, anyone who had an underlying condition needed to be taken into consideration. And I think lessons from viral infection, like Ebola, for example, in West Africa, was supposed to be one of the key lessons that countries like Kenya, like low-income countries like Kenya, should have embraced and adopted, because we saw in those West African countries of Sierra Leone, Liberia, Guinea, Benin, during the Ebola pandemic of 2014-2016, there were so many women who were pregnant who really suffered because of course, when you are pregnant first, your immunity is already compromised. Yeah. Now imagine you are pregnant and you are already living with another condition. Or you're not just pregnant, but you have other underlying conditions. That needed to have been a first sign as to why it was important for these people or this group of vulnerable populations to be taken into consideration even in the response. That was missed out. So for me, going forward, and even as we continue responding to the pandemic, and even as we think, because we don't know when another pandemic is going to rise, we need to learn from the past. And I feel like we are in a country we rarely learn, or we learn, we live, and then we come back to something else and we move. We need to move. We need to learn from contexts that are almost like ours, and learn and plan. And not just learn and plan and write it down. Learn, plan, budget, implement. I feel like that is what has been lacking, and that is why we are seeing many people are really being bearing the brand of this pandemic. Actually, people who have been living with something else. Imagine if that was taken into consideration when we were thinking lockdown, when we were thinking curfew, when we were doing the restrictions. Imagine we had a good data health information system that was responsive enough to be able to pick all these people. Imagine if we were using that data for decision making. We would not be where we are today. We would not be talking about what we are talking today. So I think moving forward as a country and moving forward in respond to this COVID and other conditions that are going to find us, even in the normal response to conditions, we need to take into consideration the element about the vulnerable and the marginalized. But even within the marginalized and vulnerable, there are other marginalized and more vulnerable. If we are really going to, and let me bring on the aspect of the UHC or universal health coverage that we keep on talking about, issue about equity and fairness needs to be brought to perspective. The issue about quality. What care are you giving? What care are you pushing for? And for who? Are you saying that poor people should get poor quality of care because they are poor? No. It's about how do we reach the unreached first? How do we ensure that we leave no one behind across board, and that we do not just work on the numbers, work to say that on the averages, that we don't just work on what is available and what is really easy to reach, but really reach the unreached and budget. And then brings out the issue about ensuring that we budget based on what is needed. And as a country, how do we fight the element of corruption to ensure that even that what is budgeted reaches who are supposed to be reached, and whatever is already in the budget does not leak? Because we have a lot of money and resources in place in the counties and in the central government. But why are we having so much of these leakages? And what is being done to ensure that these leakages are addressed at the end of the day?
And I'll take that as your parting shot. Angela, over to Narima, your parting shot, even as we seek ways to safeguard maternal health care in the country.
Thank you, Gladys, and thank you for this opportunity. I would just say as a parting shot, it's really important for us to ensure that the legal and policy framework that we have in place translates into impact on the lives of people in this country. Otherwise, it's just laws on paper. We have discussed that we need to have available, acceptable, accessible, and quality healthcare. Dr. Kaliti went into detail on what quality healthcare means, but we still have challenges on availability, accessibility, and acceptability of services. So even as we have a discussion on quality health care or quality maternity care, are these services available to women? Are they accessible to them? And are they acceptable depending on different cultural contexts? We have taken very many good strides and steps, particularly around RMNA, reproductive, maternal and newborn health, in terms of our legal and policy frameworks. And the government of Kenya took a very quick first step in having a policy in place to guarantee essential services. However, a policy does not translate into impact. We actually have to do things thereafter to ensure that this policy is a reality. And the Ministry of Health has to work closely with county governments. We've heard from county governments that they don't actually have the information that they need. We've heard from people on the ground, they don't have the information that they need. So it's about time we start to look through what the interministerial committees are doing, what the Council of Governors is doing, and how these mechanisms can be used to improve the lives of Kenyans. And thank you so much for having me.
You're welcome. George, how and what can be done to deliver solutions that work to help zero-rate maternal deaths and infant deaths in this country?
Thank you. I think the most important thing to learn from the situation of the corona pandemic in the country is preparedness, both at the facility and the community level and also at the policy level. The policy level, the national level need to have a very effective response team at all the time, not a rushed formed teams that create confusion across the board on how to start and how to respond, which takes a lot of time in development of protocols, guidelines, and policies that we have seen in this situation. Secondly, there is need to engage with the county level. That linkage between the national and the county level need to be very clear pathway, whereby the Council of Governors take responsibility to engage with the national government on how to disseminate the policies that have been developed and put in place on time, and therefore prepare the ground at the service delivery level, which is the implementation level, to ensure that these protocols and policies are implemented properly through the domestic resource availability and allocation, which is transparent and accountable to the public, and also to ensure that the services reach at the household level by creating a space for the community health workers to provide these services with assurance that they are protected. Currently, they are working in that space, but look, they are not under any healthcare protection. They are not protected by national health insurance. They are not protected, and therefore, when they get infected, I want to assure you, certain statistics, which I may not verify, states that some of the community health workers have succumbed to death because of COVID infections. And this one is because they have walked in willingly to support the communities in terms of sensitization, making them be aware and know where to seek the services, but in the process, they get infected. And therefore, we need to support community health workers, recognize them as the healthcare workers on the ground through the policies and the legislative process, which currently is in the assembly. That should be protected and supported. That law which is coming out, everyone should protect it to ensure that it is allowed to take place so that these people get their space to work without fear or intimidation. Thank you very much.
Thank you, George. And Dr. Kaliti, you represent the Big Brother. You've had an appraisal of maternal health care in this country. Shortly, what can you promise the mothers of this country?
Now, for the mothers of this country, just to let you know that the government has you covered. I know everyone has a role to play, but we are there to make sure that this role is played well. But most important, I know COVID-19 has wreaked havoc in the pockets of many families. So in recognition of that, please, I appeal to you, each and every woman, please enroll for Linda Mama. It is our avenue of bringing resources for health to you in your hands. We'll be able to take care of you through Linda Mama. Please make it a universal priority for yourself. The moment you discover that you are expectant or you're expecting a baby, please enroll for Linda Mama and you'll be having access to all these sorts of, care. And again, I want to tell you that please come to facilities. We have put a lot of measures to make sure that they are safe for you. And although there may be a few teething problems here and there, they're still the best bet you might have when it comes to your outcomes or to taking care of yourself and the life of your newborn. So please utilize these services. The government is working overboard, and I'm happy to report that we're increasingly funding more and more of healthcare, especially reproductive health. And this year alone, the government has funded the highest amount that you can think about when it comes to reproductive health. And we need to take cognizance of that. And I want you to play your role by demanding for these quality services when you go to the facilities, so that you also keep us on our toes, that we'll be able to serve your need, and you're going to be responsive to what exactly you need as Wanjiku, as a common woman who is utilizing these services. Our ears are open. Thank you.
Thank you, Dr. Stephen Kaliti, Head of Reproductive and Maternal Health at the Ministry of Health, Angela Ngoko, Executive Director, White Ribbon Alliance Kenya, George Owele, Community Health Strategy Advisor at AMREF, and Erima Were, Program Manager, Sexual Reproductive Health Rights at Kelin. Thank you all for your time. Now, tomorrow, we take a look at the changing face of religion. For example, the Akorino, known to be conservative, now make one of the best contemporary dancers and fashion models. The contemporary style of gospel music seeped into the church, and today is a norm that has many attracted to the new tune. So how has religion embraced these changes by keeping to the moral fabric it represents in society? We shed light on this and more from 7 a.m. tomorrow. See you then.